Thank you for joining me on Women's Power Hour today. And today it's a little bit later because our guest today is Dr. Kelly Casperson, who is over the pond, over in the States. And we're going to be talking today about testosterone and also genitourinary syndrome of menopause. She's a urologist and also does a podcast, You Are Not Broken. And we're both here to help women, empower them, and also to answer your questions. Testosterone is always a topic that really gets a lot of women sort of discussing, and I've had already loads and loads of questions. And Kelly's going to be about 10 minutes late today just because she's seeing her children off at school. As you know, many of us women sort of juggle so many different aspects of our life. And if you've got questions, then do just comment below. Okay, and just fire away. And I'm going to start answering some of these questions, and I'm going to talk a little bit about what testosterone is, because, you know, we hear a lot about estrogen, we hear a lot about progesterone, and those are our sort of dominant female sex hormones. However, we also, as women, need testosterone. And actually, our estrogen is made through what we call our androgen pathway. So our ovaries and adrenal glands produce testosterone, and it gets converted to estrogen through enzyme aromatase through the pathway, so that we as women have most of our testosterone converted into our female sex hormones, whereas for men that doesn't occur. So for many of you who may not be aware of that, that's why we as women it's also very important for us to have testosterone on board. We need it for muscle mass, for metabolism, for mental health, sharpness, for the health of our sort of genitourinary tracts, libido, desire. And if you've got any questions around any of those things, then do just post them below, and we'll start answering them. So let's have a quick look what's going on, because it looks like, let's have a quick look. Something seems to be, oh no, who's watching? You're all here. So, you know, one of the questions I get asked about here in the UK is, why are GPs reluctant to prescribe testosterone, or why is it so difficult getting hold of it? Now, there are a few reasons for this. One, there is no female licensed testosterone product within the NHS. Okay, so the only female licensed product we have in the UK is Androfem, which is shipped in from Australia. And most of the time this is prescribed you know, via a private doctor like myself. Or, you know, if your GP does prescribe, it will probably be under the recommendation of a menopause clinic, or if they feel comfortable in prescribing it, it will be a male testosterone or one licensed for men, like Testogel, Tostran, Testim, which they then titrate according to a female dose. So that's why, you know, GPs find it hard to prescribe, because they don't have the access to a female licensed testosterone. Also, when they are prescribing the male version, they are prescribing in what we say is an off-licensed way. And so what happens is that they are taking on board that risk along with you in prescribing it. And also, when we prescribe testosterone, it is usually the tertiary, the third hormone prescribed. So, for example, if you are a woman with a womb, you will get prescribed estrogen, progesterone, and then testosterone, because we need to boost those estrogen levels before we can start prescribing the testosterone. So Kelly's here. Let's get her on, and also tell you, and we can talk and discuss testosterone. I'm just going to check. Kelly, are you? Yes. Hi, Kelly.
Good morning.
I know. Well, for you, for us, it's afternoon, and you know, I really appreciate you coming, waking up early for us. But you've had a bit of a time change as well. Is that right over there?
We had a time change like last weekend. So
okay. Okay. So tell us
So
a
here
little
we
bit
are.
about yourself, because I've been sort of singing your praises. You're a urologist, you know, out to empower women, you know, answering and you know, covering topics which not all doctors feel comfortable doing, you know, sex, libido, hormones, you know, pelvic floor, all of those kind of things. So just give us a little bit of background and insight into you, because I've only seen you also on Instagram. I love the work that you do, and so it's really nice to connect with you.
Thank you. Thanks for having me on today. So I'm a urologist. There's about 1,000 female urologists in the United States now, or about 9% of all urologists in America. About 4 years ago, I started a podcast after I learned a lot about female sexual health. And the reason I learned a lot about that is because I had a patient who was being challenged with that, and I didn't know how to help her. Okay. And I just assumed the gynecologist knew. It turns out they don't know. And the more I learned, the more I'm like, I can't keep this to myself. I need to talk. I can't help enough people coming to my clinic. So that's the podcast is about 4 years old now. It's called You Are Not Broken. Started the Instagram to get more people to listen to the podcast. And so that's going well. And came out with a book. It's going to be in its second printing in September. And it's called You Are Not Broken. Stop Shooting All Over Your Sex Life. So it's not out right now. You can pre-order it on Amazon, but we've taken it down for its second edition.
Perfect. And so just for those who don't know what a urologist is, because often we associate that more with male patients. And you're maybe many people have come across urologists because they've been, their male partners or have been referred there, or they know somebody's gone there. So just talk a little bit about what a urologist is and why it's important also for female health. Yeah. Or why why urologists are important. Yeah.
So urologists are surgeons of the genital urinary tract, kidneys, ureters, bladder, prostate, classically the male sexual structures, scrotum, testicles, penis. But more and more, because urologists are very well trained in sexual function, we're very well trained in testosterone. So more and more urologists are comfortable with female organs. I treat bladder leakage, prolapse, all of those issues. Clitoral phimosis is a big one for orgasm issues. The skin of the clitoris can come over the clitoral head and cause either pain or decreased sensitivity. So urologists are very comfortable with both hormones and sexual health.
And I think some of the things that you mentioned there, like clitoral phimosis and testosterone, it's something that we're learning more and more about, particularly when it comes to testosterone, how important it is for a female body to function well, and especially when we get to perimenopause and menopause. And I think one of the things that I think a lot of women are almost surprised to hear is how important testosterone is for the female body.
Yeah, I mean, we have to take a step back, right? Because so many people don't know testosterone is in all bodies.
Yes.
We've really done a disservice in two ways. Number one, we call them sex hormones, which is very dismissive of their importance in the brain, in the bones, in all of the body. But they labeled them sex hormones in the 40s and 60s when they were discovering what they did, specifically in the testicles and ovaries, right? So number one, we labeled them sex hormones. That's a problem. And then number two, we gendered them. We said estrogen's for women and testosterone's for men. And that basically erased the possibility that men can have issues with low estrogen, women can have issues with low testosterone, because it's in every body. And I'd say the third thing is, since estrogen's the female hormone, we erased the fact that we actually have more testosterone in our bodies than estrogen. I didn't learn that in medical school. I had to learn that part in my journey now of sexual health and hormones.
Similar.
We have more testosterone in our bodies than estrogen.
I was just going to say, similar for me, here in the UK we have GPs, and I'm a GP who then, because of the need for, I felt that, more specialised care in perimenopause and menopause, went away to kind of learn more about it, and particularly around sort of sexual health, libido, orgasm, sort of those kind of aspects of female health, which, because growing up almost felt like when you got to in your mid-40s and 50s, sex was off the table, but actually it's so on the table, literally almost sometimes, it should be and could be. And I think the whole thing about testosterone growing up as well as a medical doctor is you do get it pigeonholed that it is a male hormone, a male hormone, a male hormone. You're not really told that much that as women you may benefit from it, or you actually have some, and actually your estrogen is made through that aromatase pathway. We don't get told that.
Yeah, if we want to be technically accurate, the ovaries make testosterone and androgen, which then make estrogen.
Yes, yeah.
we say the ovaries make estrogen. Like, not technically. Technically, they make androgens, which then get converted to estrogen.
Which gets converted. And so, one of the questions I've had in, and I get asked this a lot, in a way, and it's very, I often think there's no sort of black and white answer, and just want to know what your thoughts are. Somebody's asked the question, what are considered normal ranges of free total testosterone for women? And what is well, I suppose the next part of the question is something we can discuss separately, and what is its safest form?
Yeah. I mean, people will give you vague answers to that question, I think, for a couple of reasons. I think number one, we don't have a lot of research on what normal is. Normal fluctuates when you're cycling, right? Your testosterone is highest when you ovulate. So there is no, and this is me after reading a lot of research, there's no normal in, like, what's your normal estrogen when you're 27? Well, where are you in your cycle? Are you pregnant? Right? Like, there's so many things that this whole normal, and I think what people are asking is they want to try to be normal, right? And so I'm like, we don't have normal.
I think that's a good point, that they want to try and be normal. And also, the normal is a range. One of the things I say to women is the normal is a range, and you're the normal for you and the normal for me can be quite different. Also, testosterone can be bound, and so a total testosterone level could come back looking at the upper end of normal, but your free active testosterone, your free androgen index can be much lower. So in the sense of, you may not be getting the benefits of your testosterone because much of it could be bound in sex hormone binding globulin.
Yeah, that's absolutely right. So yeah, it's a longer answer to the question because of all those caveats. And I always tell people, I don't treat you to try to get you to a level. Yeah. I treat you for symptoms, and then I'll use levels to make sure we're not going too high, right? If you still have, like, for example, a woman's like, I think I want more, but then I'll check her levels and be like, it's actually pretty high. Your symptoms are probably not because of low testosterone. Yeah. Right. And so I'll use it.
That's a really good point. And that's the same thing, to ensure that your levels aren't, one of the reasons for testing is to ensure that your levels aren't physiologically high. And sometimes I think people can put down their symptoms always onto their hormones and forget about environment, forget about the relationship, sometimes there are, sort of unseen, unsaid things between, a couple, relationship. And these are things that impact libido and your ability to get aroused and orgasm. And I think communication and understanding that aspect is key. And like you, sometimes measurement of a level is to then almost like to sort of eliminate a cause. And so look, and sort of, because it's much easier in some ways in all of our heads. And I'm going to say I'm the same person here. We all are, to treat an organic cause, to treat a number or something that you can get your hands onto, rather than thinking, well, actually, is there something else going on? Am I not sleeping, or have I got financial stresses? Because most of us at some point in our lives will have a loss of libido, but there could be multiple different factors going on. And I think that also also one of the reasons I check levels is to ensure that we're not going to cause any side effects. And one of the biggest side effects, I think, for some women, especially in perimenopause and menopause, would be hair thinning and hair loss on your head, and hair in other places that you don't want it.
Yeah. And, I think we see over here, because we have failed to give women physiologic dose testosterone, our FDA's failed to provide a product, our insurance doesn't cover a product, so women go out and they get pellets. And this is my analogy, is if I take you from sea level to Everest Base Camp, it feels kind of crappy, right? So the pellets can go very high. You can have high side effects. You can't reverse them. I do think some women do better at higher levels, but we got to get you there slowly, because your hair will fall out. They're very upset.
And look, I can talk from experience, actually. When I was probably about 10 years ago, and I saw a gynecologist, and he sort of talked me into having a pellet at the time. And I have to admit, I was horny as hell. Okay, that just went off the scale to the point that I was running on the treadmill to keep myself sort of calmed down. But the other thing I really lost was a lot of hair. I lost a lot of hair at the time. Some of it's come back, some of it's restored, but it's nowhere near where it was at that point. And that's my biggest thing. hair loss and hair thinning affects women's confidence and mental health. Their self-esteem so significantly around this time that the last thing I want is for somebody to suffer that side effect. So, I would prefer to go a little bit lower and slower than rather sort of rush in. Let me ask you a specific question, because somebody asked, and I think you're the perfect person to answer this, is how does testosterone help with genitourinary syndrome of menopause, and how
Yeah.
can it help?
So our genital tissues, clitoris, vulva, labia, vagina, there's androgen receptors everywhere down there.
Yeah.
So estrogen works, but androgens also work. Now we have one product in the US, it's called Intra-Rosa, or it's intravaginal DHEA.
Yeah.
DHEA is a precursor hormone, and it goes to androgens and estrogens. It makes beautiful vulvas and vaginas. This is an amazing medication. You can also get, I do often a compounded estrogen testosterone cream. Really helps with, if you have clitoral atrophy, decreased sensation, testosterone can really help down there. And there's some women that just don't respond quite as well to a pure estrogen product as they do to adding an androgen to it. And that is local testosterone, not systemic testosterone.
Unfortunately, we don't have that here, but but very much like you, I do often advise a estrogen cream, using it almost like a moisturizer for the clitoris, for the vulva, for the labia, and that does help. Yes, it doesn't work for every single woman, but for a lot of women, it can help to enhance and sort of sensation, and also help to improve blood flow, circulation, and plump things up a little bit. And also, like you said, testosterone within the vaginal walls really does help with that sort of vaginal environment, and really helps with lubrication, sensation, and really can enhance that. This is an interesting question, because I get asked this, and I have a one-to-one discussion with with each woman individually. Thoughts on testosterone use post breast cancer while taking aromatase inhibitors? And I know there are some studies going on at the moment on this as well.
So that's a great question. So for people to understand, what aromatase does is it converts testosterone to estrogen. So if you're on an aromatase inhibitor, you're not going to convert any of your testosterone to estrogen, right? You're going to take testosterone, your body's going to use testosterone, you're not going to convert it. Testosterone, multiple studies have been shown that it does not increase your risk of breast cancer. We have, I would say, a good amount of safety data on this at this point. So we know testosterone's safe. We also have papers. There's this amazing paper looking at musculoskeletal pain in breast cancer survivors on aromatase, because we know when we block our estrogen and have low testosterone, we get muscle aches and pains. So they did this. They had women on aromatase inhibitors and they gave them testosterone. Now, it's an interesting paper, because the paper says it did not improve musculoskeletal pains with aromatase inhibitors, but it improved lean body mass, mood, hot flashes. Like, testosterone improves many, many things. And to me, I'm like, if you're miserable, talk to your doctor. You might have to talk to a couple of them, but I've got data to say it's safe now. Certainly, if a woman came to ask me, I would run it by their oncologist and educate them, because they might not know these papers. But to me, I'm like, more and more. Quality of life matters.
I think that's what it comes down to. I think it's quality of life, and I think having that sort of informed conversation with each woman is really important. And I see I see a number of patients who are breast cancer survivors, who are on aromatase inhibitor treatment. We have this conversation, just like you said, and we talk about testosterone being so much more than libido. It helps with energy levels, sort of mood, motivation. So I've had women who've had breast cancer and say to me the worst thing about breast cancer was coming off their hormone treatment. Because everything went dry. They felt they didn't feel like themselves. They got so many different symptoms. They just felt tired. And they felt unable to then talk to their doctors to sort of say, look, this is the way I'm feeling, because they felt they should just be grateful for having had their breast cancer treated. So actually, I found that, usually I find that the testosterone works better if we can have estrogen on board. However, it works well on its own too. And I do prescribe testosterone to those women in early perimenopause who may not need estrogen and progestogen, so just testosterone on their own, because they come in telling me they are feeling, sort of demotivated, tired. That again, it's not all about sexual function; it's about their quality of life. Their body mass or their body composition is changing. And then also those women who are sort of that post-menopause or who have had breast cancer treatment, who are missing out on their sex life, are feeling that they're gaining weight, and their metabolism slowing. They feel that brain fogginess. In your view, on those patients, do you run them at a slightly higher level?
Yeah, I think they do. And again, I get them there slowly, right?
Yes,
I put them on the standard dose. We can always go back up. But I think it's an important point because so many, like the myth is ovaries and adrenals will keep making testosterone after your periods are done, right? And so they'll say, well, estrogen goes off a cliff, but then testosterone kind of does a slow. And I'm like, not in my experience. There are many perimenopausal women with very low testosterones. And so I don't always believe that graph where the testosterone's falling down like over here. I'm like, no, it's falling down over here for a lot of people.
Yeah, I mean, I was at a conference, the European and European Menopause and Andropause Society last year, and there was actually a speaker from the US, and she'd gone into an earlier menopause, and she said actually she felt that we should be almost reversing things and starting women off on testosterone and then adding the estrogen, and then and then adding the estrogen and progestogen, and that really sort of helped to change the way I thought about a number of things. And I was at the International Menopause Conference once, and a male gynecologist sitting next to me from Australia said, he put his wife was on testosterone from her, 41, 42 years of age, because she just felt she was lacking that energy and strength and stamina. Again, it was not to do with sex and libido. And I think you're going back to your point that we have these androgen receptors all over our bodies. And I think it's just the fact that that not so much research is being done on midlife women. The money hasn't been sort of pumped into us. That's why, we're lagging and not getting what I think is the care that we deserve.
Well, yeah, I mean, I think it's nuts that libido is the only approved indication for testosterone. No. First of all, libido is mood, right?
Yes.
So like libido is the brain is mood.
Energy and sleep and everything. Yeah.
Yeah. So Australia is currently doing testosterone studies looking at sarcopenia and looking at mood. So like I'm just waiting for that to come out because but for people to say we don't have data is insane at this point. Like there are studies. We've been putting women on testosterone since the 40s.
Yes.
Every time I read a paper that says we don't have enough data, I'm like, are you just not looking? Like we've got, let alone bone health. There's a paper looking at estrogen alone versus estrogen and testosterone for bone health, and the combo has better bone strength than the estrogen alone.
Okay, so let's ask another question, and I like this question because I get asked, because here in the UK we have testosterone in the form of a cream which comes from Australia, the Androfen cream, and then we have the gels which are the license for men, but then we titrate and tweak for women like Testogel, Testim, and Tostran. But what about DHEA versus testosterone? So oral DHEA versus transdermal testosterone.
Yeah, so DHEA in America is a supplement, right? Okay. So you can buy it like a vitamin at the health food store. The problem with that is it's a completely unregulated industry.
Okay.
The problem with our supplements is I can't tell you that what it says on the label is what's in the product. So that's our problem with DHEA is like buyer beware. It might be 25 milligrams, but who knows? Okay. So that's my one issue with DHEA over here, besides the vaginal DHEA, which is a prescription strength. So that is what you get. In my experience, in DHEA, you're going to get a rise in testosterone and estrogen. I think it's better in the perimenopausal women when you still have the factories, working. But it's not huge spikes. I don't think it's harmful. It's not, as a prescriber, it's not my first go-to. But if people want to try DHEA at home and see if it makes them feel better, I don't think you're going to hurt yourself.
I think it also takes time. There was some Italian research and studies looking at sort of 10 milligram and 25 milligram doses, and it does take about 6 months really to for you to sort of notice any difference. Whereas with testosterone, we tend to say about you should start to notice some difference within sort of 3 months. In my experience, what I find is the younger woman, the perimenopausal woman, you'll probably notice a difference a bit, or notice the effects of testosterone a little bit sooner within those 3 months. And with the postmenopausal or the older woman, I usually give it at least 6 months before I sort of give up or not give up, but sort of say maybe there are other things going on and it's not necessarily testosterone that's needed, or the answer. I sometimes have women sort of say, look, and I've had some questions saying, I've been taking testosterone or applying it for the last 6 months. I've not noticed a change in my libido. And I think, again, it goes back to the question, well, actually, are there other things going on? Let's break it down. I often talk about, sort of hormonal health like a sponge cake, a layered cake, that there are loads of different layers, and hormones are one aspect of it. There are lots of other things going on, and maybe we should be addressing part of those as well.
Yeah, I mean, libido is so wonderfully complex, right? I had a woman ask for testosterone for libido. She was in marriage counseling. She was getting a divorce. And she had significant relationship issues, right? And it's hormones are not miracle workers. They are wonderful, but they're not miracle workers. The other thing for if it's not working in 6 months, that's when I would check levels. Are they absorbing it? Things like that. In America, just as far as to answer the question of how to get your testosterone, in America, we can compound injectables.
Okay.
And they're coming out with a low dose oral form, safe, undecanoate oral form at the end of the year. It's going to be expensive, but there's going to be more and more different ways to get a physiologic dose so that women aren't, the pellet companies are massive companies because our traditional healthcare system is failing to take care of women.
Also, with the transdermal versus the oral, are we able to control the levels better though transdermally because of the bioavailability? Of oral injection is going to be different.
We're gonna have to see with this product. So this product, it's unique. So it goes through your lymphatic system, not your liver. So you're not going to get liver. That's why we traditionally don't have oral testosterone, right? Liver toxicity. So it'll be interesting to see what this product's going to offer.
Okay. And I think, for those women who haven't noticed a difference on their preparation of testosterone, because I've got some questions in sort of saying, I'm on Testosterone prescribed by my GP. My testosterone levels were low, but feel no different. Should I be on a higher dose? I think that sometimes women do underdose, and I've seen this a lot, because we don't, especially with the testo gel sachets and the sort of the versions licensed for men, because there's no sort of measure as such, and we're using a pea-size measure. Often I do find women are using maybe like a petit pois rather than a pea, and we need to sort of be, it's almost like I was almost going to say it's homeopathic, because the dose is so small that they're applying, they're really not getting the benefit. So I think you do need to, and here in the UK, what we tend to do is to measure levels after about 3 months if things aren't working, and I think that it would be appropriate to do so when it says they're applying it, but they're saying they're not, that they're not feeling the benefits. And also, again, to answer Caroline's question, it's not just about your total testosterone, Caroline, it's about your free androgen index. So when you're measuring testosterone levels, we should also be measuring things like sex hormone binding globulin. We should be working out what your free androgen index is to see actually, even though you say you're applying the right dose, are you getting that within your body, or is a lot of it still bound? And the other thing when women are on testosterone, sometimes is if they are on an oral form of estrogen, it's better to change them to testosterone so that their SHBG is then, is maybe not as high, so they get more of that free testosterone. So there are a few tweaks that, Caroline, that you can do. If you are on an oral HRT preparation, maybe we change to a transdermal, and then you might find your testosterone levels start to come up or feel more effective.
Yeah, and I would add, again, another myth is that testosterone is the hormone of desire. There are many women who get on estrogen and they're like, I'm good. My desire's back. And I think we've labeled these hormones as this one's for this and that one's for that, and they're very complementary and they're not the same in everybody.
And that leads us on to a really good question or good thought, because one of the things I also, I think a lot of people, like on social media, they hear testosterone, and like you said, they think it's a hormone of desire, or it's, every woman should be on it. But actually, many, and I see this in clinic, many women feel great, just when they start on estrogen, because, they're sleeping better, they're less tired, they've got more energy, their hot flushes and sweats are calmer. So, and not every woman benefits from testosterone. Not every woman, gets this sort of spark or changes in the way that maybe you hear some celebrities speaking or some people speaking. And I think that's also normal, because we're all very different.
That's right. Yeah. I mean, and I think we are at least 10 years, it's going to come, but I think it's too soon to start saying, should we be taking hormones for preventative health? Now, testosterone is very, very interesting. We've got decent papers saying women who have normal physiologic testosterone, they have less risk of breast cancer. They have less risk of heart disease, right? But we can't take that and say everybody should be on testosterone for preventative health. But I think about that because a woman's like, I'm totally happy on estrogen. Should I do testosterone? And I would say right now, most people would say no. But I always think testosterone's healthy for us. Are we going to get to that point? Are we going to get to that conversation in 10 years from now? Well, I hope so.
Well, I also get asked the question by some women as well, who maybe don't have many perimenopausal or menopausal symptoms, is should I be on hormone treatment for primary prevention? So what like on estrogen and progesterone, so what are your thoughts on that, Kelly?
For vaginal, I think we've got good data to say you can be on vaginal estrogen for prevention. There's just a new paper that just came out saying if we put every postmenopausal woman who's on Medicare, which is our state or national insurance for the elderly, if we put every postmenopausal woman on vaginal estrogen, we would save Medicare billions of dollars annually just in urinary tract prevention alone. Urinary tract infection prevention.
And this is something, I often talk about vaginal estrogen, that, women should be almost like given it in a little goodie bag as soon as they turn 40. I mean, I don't know if you in the US have things like bounty packs when, when you're pregnant, you get given a little sort of hamper of, nappies and things. So I almost feel that we should be given this sort of, and maybe this is me showing my age, because maybe nowadays young women don't get, bounty packs or anything when they get pregnant. But I always feel that when we turn 40, we should be given this little, almost like this bounty pack with vaginal estrogen being a part of it, because I think that this is also a myth we need to dispel, that vaginal changes don't happen when you're old. People think that it's somebody in their sort of 70s plus, they start to occur much earlier, much sooner. And especially even in younger women who are on the combined oral contraceptive pill, many of them are experiencing, vulvovaginal dryness, recurrent thrush, recurrent UTIs because of the low estrogen. So I think, we should be looking at that almost like as we put moisturizer on our face, we should be looking after, our vulvovaginal health in the same kind of way. And as we said, it's good to know that there are papers out there to sort of say that we should be looking at it from a preventative health point of view, to prevent UTIs, and with that means less antibiotics, less changes to the gut microbiome, all of those positives that can come from just managing those symptoms. Well, look, I could talk to you forever, Kelly, and I really, really enjoyed our conversation, and I think it's really nice to have sort of a rational conversation around, testosterone, and talking about it from a health physical health, but also from, a quality of life, what possibly could be happening in the future as well. And maybe we can do a part 2 at some point. That would be amazing.
It's so fun for me to connect with people who are in different countries,
Yeah.
seeing the same thing, thinking the same way. Like, I love it. It's so cool. We're all
That's the
trying our
power
best
of
to take
social
care of women.
media, isn't it? It's the power. Like, we would never have connected otherwise. And I likewise, I was thinking, gosh, we're talking across, continents here and things like that, and talking about things that we both feel really passionate about. And I love your posts, and I love, let me just see if there's another couple of questions that come in that we can ask. Someone said, and I don't know if you've heard of this, because I've never heard of this, Kelly. My doctor gave me a testosterone troche that dissolves under the tongue. I feel like I'm shedding a lot more hair. Is that possible? Have you come across that?
Yeah, so that's
Is that
very common it's very common in America, again, because we don't have good products for women, that we compound them. And so that's a compounded product. You just put it in your cheek. My guess is her doses she's going way too high. Right. And again, you need somebody who knows what they're doing, that doesn't want to get you too high, because this woman will stop taking hormones because her hair falls out, and she'll miss all the benefits of an appropriately dosed testosterone product.
And that's such a good point that you make there. And that's one of the reasons why I start off a little bit lower, because I know that, that she could benefit from the hormones. And the last thing I want is for somebody to get side effects, which then, puts them off, when actually in the long run, they will benefit. And when I say, we go slow, I don't mean we're taking years. We're just taking a couple of extra months to get there,
Right.
And so I just want to say that to people out there, if you do want to book in, if you do want to come and make an appointment, then do email. But, it's not a question of you have to wait months and months and months. It's just about ensuring that you don't get any side effects before we go up a dose or increase the dose. Because ultimately, as we've been talking, women can really benefit from hormone treatment, and it can really help to improve their quality of life and empower them.
Yeah, I mean, one thing we haven't talked about, but it's the amazing brain effects that women are coming, they come in and they're like, I'm faster. I'm thinking like I thought when I was 30. Math is easier again. Yeah. Like, the fog has been lifted. The veil's been lifted. Like, the things that they say as far as mental clarity, I'm like, it's insane to me that this isn't more widely talked about.
And maybe that could be our part 2, because I'm totally in agreement with you, because I think we've got so much of a life to live. And to be fair, one of the things I often say is, it's one of the reasons how I do what I do, because I'm on my hormones. When my hormones started to decline, one of my big symptoms was that brain fog, feeling slower, less sharp, less sort of on the ball. And I was thinking, am I going to be able to carry on as a doctor? And I love being a doctor. How's that going to affect me? And then and now here I am, sort of powering through and enjoying that next phase of life. And I really want other women to appreciate and feel that, if that's what they want. And also, it's great in the grander scheme of things, and that's why governments need to take note, from an economy-wise as well.
Yeah. Well, yeah, I think the UK is ahead of the US looking at the economic impact of untreated menopause. Yeah. Of like, if you don't feel like you can be at your job, that's a profound impact for both you, your family, the country, the economy. And I mean, it comes down to like women feeling like themselves. Yeah. They come back and they say, I feel like myself. And I'm like, you can't measure that in a study. It's very hard to measure. But I would argue it's the most important thing.
And the simple things. Sometimes I've had a woman say, look, I went on a walk and I was able to walk further. I was able to cycle. I felt stronger. It's not about being a power lifter or anything. It's just about feeling that they've got stamina, energy, that they can sit at the table in a way and hold their own. So thank you so much for joining me from all the way over there. Really appreciate it. And like I said, maybe we can do a part 2 and focus on brain next time. So that would be amazing.
That'd be
Thank you.
Great. Thanks for having me.
Thank you, everybody. Bye.
Bye.